Hello, everyone. Welcome to our panel review on psoriatic arthritis from EULAR 2025. Our faculty who covered PsA are here to discuss highlights of this meeting that was held last week in Barcelona. We were all there. We were all working from 6 in the morning till midnight covering this content. We found a lot of content that I think you're going to like. We're going to do everyone's going to do two presentations of their favorite things of the meeting, and hopefully this will be informative for you. Um, let's begin with introductions. I'm Jack Cushwood, room now. I'm joined by Orly,
Hey, I'm Aurelina from Glasgow, Scotland.
Jiha,
I'm Jiha Lee from Michigan.
Nelly,
I'm Ellie Ziadeh from Beirut, Lebanon.
and Eric.
And Eric Ruderman from Northwestern in Chicago.
Excellent. All right, so let's get into it. Orly, what's you're going to lead off the program here.
Yeah, so I wanted to talk to you guys about the oral presentation 0089 that was presented by Laura Coates on the first day of the conference, and it was about the SPEED RCT. SPEED stands for, I'm gonna have to read that, Severe PsA Early Intervention to Control Disease. So basically, they looked at patients that were naive with PsA but that had a factor of poor prognosis that was identified as either having polyarthritis, CRP over 5 milligram per liter, HAC over 1, or erosions at diagnosis. And so what they did is they randomized them to 100 people in either a standard kind of conventional synthetic DMARD and then step up, or a combination of conventional synthetic DMARD straight away, so either methotrexate, N-sulfasalazine, or leflunomide, and an arm that had TNF and methotrexate, so they had adalimumab and methotrexate straight away. And the major outcome there was the PsDAS at 24 weeks. So they were able to show that the people that were treated with either the combination of conventional DMARDs or the TNF, they had a better reduction of the PsDAS, and that was significant in both of arms. It was 1 or 0.7. The other thing is that the DAPSA was better. There was no difference, however, between the combination straight away and the TNF, which I found quite interesting. At week 48, then, though, what they saw is that the people that had TNF only were still doing better. While they had only 6 months of treatment. After that, they were going back to original treatment. And in terms of infections, it was actually not particularly bad. I mean, the same things that we see with TNFs, regardless, infections, and more so than in the conventional DMARD arm. But I think overall, to me, what it's telling us is that because we know that in RA, if we treat harder earlier, the people that have poor prognosis, they still do better after a while. I don't know that that was demonstrated in PsA. It makes sense, but I think for me it was quite interesting as a result, and I wish we could do more of that in the NHS, but we've not been very good at that so far. So yeah.
So, in a world where money doesn't matter, these are important trials about whether you're treating your mother or your mother-in-law, how aggressive you're going to be. Eric, have there been other best like trials in RA in PsA other than this?
Not really. I mean, the closest we've got is the PsA SEAM trial, which looked at methotrexate versus etanercept versus the combination of methotrexate and etanercept, and said that etanercept worked better than methotrexate. I talked to Laura about this trial, and she was kind of hoping that they could show that the biologic actually worked better because then they could go to the NHS and make that case when they thought it was appropriate, but it didn't. It was as good as a combination of conventional synthetics, and that left them where they were. And ultimately, they had to come off the biologic because the NHS wouldn't continue to fund it. And so that's troublesome because early biologic doesn't leave you set up for the long term. So I don't know. I think if you can't get a biologic, this was promising, but that's about it.
Yeah, maybe it changes the way this kind of data changes the way people practice. Jihan, Nelly, what do you think?
Well,
No.
I think cost effectiveness matters a lot. And I'm not sure if measuring the endpoint at 24 weeks is enough. Maybe we need longer follow-up to see superiority.
But that's why I think that one of the 48 weeks outcome was really important because then, although they stopped the TNF, they're still doing better at 48 weeks. So maybe that's the hit that the disease needs at the beginning to kind of like slow down a bit, and then you can maybe go back. I mean, we'd have to see longer term, but I think that the 48 weeks outcome was quite interesting in that matter. Yeah.
Jiha, is there another way to think about this?
Well, I think what Dr. Roderman said, I think contrary to RA, where they're finding this like concept of the window of opportunity and more aggressive at the beginning, that with PsA, maybe depending on the presentation, that doesn't hold true is kind of an interesting concept to think about. So I think, as Zara said, I'd be more curious in the long-term data of this to see where it direct leads us.
Given all the conflict in the world, I'm going to reduce this to military analogies in that this is like saying your first effort in a war sets the tone for the rest of the war, and we know that's actually not really true. And in this kind of study, and there are many of them, that first intervention, does it change trajectory of disease? And is there some long-term effect? I think we have to think about these diseases as winning many battles, many short-term battles. And primary endpoints should be 6-week or 4-week endpoints. And if you don't win those, that's the study, I think, where you really, now, of course, that can get really, very, very expensive, and may be really impractical in a lot of places. But again, if it's your mother and you're looking to do better, I think you're going to have to break out of this kind of mold. And this is traditional clinical trial stuff in its design. And that's not really wrong. It's just that there's a limitation to what you're going to get out of it. Let's go on to the next one. Dr. Lee.
Yeah, I think that kind of the one I'm going to talk about kind of goes along that, and I think definitely Laura Quotes was the star person when it came to psoriatic arthritis because she just had a plenary where she was bringing up this discussion or concept around domain identification and precision medicine. And in one of our talk, the rising star or potential new treatment was the selective TYK2 inhibitor deucravacitinib. So the study I'm going to present is a late-breaking abstract 001 by Dr. Desiree van der Heide from Netherlands, and they've done wonderful work in RA. And this was the largest randomized scale study of this kind in a phase 3 double-blind randomized control of about just over 600 patients. So they were randomized to deucravacitinib to placebo, and they looked at outcomes related to arthritis, skin, and also other domains like pain, functionality, health-reported outcomes. And deucravacitinib all did better, about 50% compared to 30% placebo. Now, I think that 30% placebo is still a little bit high, and from the abstract, it wasn't entirely clear how much steroids or other treatment they were getting in the background, but all of them were supposedly to be biologic naive. From a skin perspective, again, deucravacitinib did better. I think one of the benefits and the draw of the TYK2 is that it's more selective. So theoretically, compared to the JAK inhibitors that also hit a lot of the domains of psoriatic arthritis, there should be less side effects. And even though this was just a 16-week report out of the study, that's what they found. The only negative signal was upper respiratory infection, about 5% in the treatment group and 3% in the placebo group. But there weren't any major serious risk of infections or cardiovascular or cancer risk. Again, keeping in mind this is a 16-week. And the other thing they looked at was radiographic changes. Again, I think it's a short amount of time, but the fact that they didn't see any negative signals this early on is promising. So I think if this study does pan out in the long term, it could mean that if we identify the domains of the patients, then instead of having them cycle through anti-TNF, IL-1723, that potentially TYK2, which is a daily oral medication, and for some it's very convenient of a factor in terms of adherence, that it could be a very plausible and a attractive option.
So many of you were at this presentation, and one of the biggest parts of the presentation were the X-ray outcomes, where in their primary analysis, as they designed it, where they assumed that X-ray data would be normally distributed, Dr. van der Heide said it's not normally distributed, so they had to change their analysis. By their primary analysis, it was not significant. When they changed their analysis to a non-parametric analysis, and they looked at different subsets of people to include complete data, not complete data, that sort of thing. now the results were significant. My question to you, Dr. Lee, is that matter to you that in the primary design, that the endpoint that they set up, they didn't win, but then when they redid the analysis, they did win? Is that a win for them? Or I want to hear what people think about that.
I'd be curious a big group, but for me, I think that's definitely more of a secondary measure than a primary outcome measure. I think the primary outcome measure mostly should be based on clinical response.
Okay.
And that was clearly demonstrated in this study, both for the skin and the joint.
X-ray data is going to be a positive or a negative for them, Eric?
I don't know. I mean, it lets them. I mean, if they can get that past the FDA, which I'm not sure they can, by using the secondary analysis, even though it was clear their primary analysis, the way they were doing it wasn't appropriate. Then they can get it in the label and they can talk about it. But overall, I was kind of underwhelmed. I don't think the clinical response to this drug was as good as we would have hoped for, and I don't see it positioning itself as an alternative to a biologic where there's clear-cut X-ray, benefit and much better clinical benefit.
So that was my well. Let me ask others what they thought of the X-ray data. Were they like it or not like it? Nellie, Orly.
Well, it is justified to use a non-parametric tests when you have non-normally distributed data. So the methodology is justified. The magnitude and the significance in practice. So this is something else.
So the question really is going to be, do you need the X-ray data to be considered a competitor to the biologics? And if you don't have it or don't have it to enough of a degree, are you then going to be positioned differently, like methotrexate or apremilast, or where do you see this fitting in, Arlie?
Yeah, I mean, I don't know. I kind of like agree with Eric there. I was not massively impressed. I feel as well that, the radiographic outcome is in every trial right now at 12 weeks. I mean, is that even relevant sometimes? I just don't know if how early is too early when you look at these type of things. And I don't know. I'm not particularly. Based on this, I would not give that on my first line of treatment, that's for sure.
So their ACR 20 was a 54%, and so they had a delta of treatment effect of 20%, which is good. I think it's better than what we saw with the Primilast,
Yep.
but maybe not as high as what we saw the other ones. But now it's in a different era where trials are harder to do, placebo responses are higher.
Yeah.
So again, it's really hard to know unless you yourself start working with the drug. It'll be interesting to see. It's certainly good enough data to get the drug on the market, and now we'll have another drug to consider for PsA. Let's move on to our next one, Dr. Zayed.
So I will talk about sonelokimab. So what is this treatment? This is a nanobody derived from camels that have smaller immunoglobulins that can be used to bind antibodies and produce TNF or interleukin-17 inhibitors, lightweight and more specific to what we are trying to target. So it's a novel interleukin-17 AF inhibiting nanobody, high affinity and designed to reach really the difficult to reach sites of inflammation. So the first time it was presented, it was at EULAR 2024. It was the ARGO study, 24 weeks randomized placebo-controlled phase 2 trial, with patients with active PsA. So patients with active PsA were randomized into 4 groups. So sonelokimab 60 milligram, no induction, 60 milligram, 120 milligram. And the fourth group was adalimumab, and it was not powered for comparison. It was a reference arm. And the patient receiving placebo switched to the active treatment at week 12. So the primary endpoint was achieved in the previous study, ACR 50 versus placebo. And it was increased further to week 24. So 207 patients. What I'm presenting now is the oral OP0096 presented by Ian McInnes. He presented the multi-domain and high hurdle outcome of the ARGO study. So the multi-domain meaning MDA rates and the concomitant achievement of ACR 70 plus PASI 100. So at week 24, up to 61% of patients achieve MDA with the treatment, and 45% to compare with adalimumab. And we know that there was a previous ceiling effect of 50-60% of MDA in previous studies with different molecules. Now, when they pooled the different active arms, more than 50% achieved MDA across key subgroups like female patient, obesity, high CRP, high PASI, etc. And for the composite outcome ACR70 PASI 100, it was achieved by up to 48% of patients treated compared to 18% in the adalimumab group. And so the ACR70, so which it's hard to achieve, was observed across all active group with high rates, so more than 37%. And regarding the skin, 63% of patients achieved complete skin clearance, 50% with adalimumab. So it was tolerated, no expected safety findings, so no IBD, no MACE, no depression, and 4 cases which were 2% mild to moderate oral candidiasis.
So I want to ask Eric, who knows a lot of these data really well. These seem inflated numbers to me, but then again, there is no arm here that's placebo controlled. Everybody's going to get drug. When that happens, the numbers go up,
Yeah.
5-10% minimum.
Yeah.
The Accelerate study, adalimumab versus certolizumab. You either got one or the other, no placebo. And they had 80% ACR20s in that study, right? So, I mean, and that's not normally not achieved. So again, how else can we explain, is this drug really that good? Eric, what do you think?
I suspect it won't be. I mean, I think we'll find out when they do a larger trial. This is phase 2. You never really know from phase 2. I think it's going to end up being another IL-17 inhibitor, and it's not going to be any different than the other IL-17 inhibitors we have. I mean, the promise of a nanobody is that it's smaller, and so maybe it's less expensive to manufacture. Well, we know that's not going to bring the price down. And it's better tissue penetration, which that I think may make a difference in oncology because we're trying to get into tumors. In our diseases where there's incredibly efficient blood flow in inflammatory tissue and inflammatory joints, I don't think it's going to matter. And so I think this will just be comparable. We'll see when they do the larger trials. I'm not overwhelmed by the benefit in this trial, and I'm not thinking this is definitely going to be better than the existing IL-17 inhibitors.
When we hear of new drugs, we think new opportunities, we think a chance to be better,
Right.
more efficacious, safer, maybe even cheaper. In the end, they never are.
Right. Well, they're never cheap.
Never are. And all the company is left with is something about the entity, right? Either in its structure, it's a nanobody, it's a dual inhibitor, it's not a JAK, it's a TIC.
Right.
And the question, we're left holding the bag, wondering, is this really unique enough to be an advantage for my patients? And depends on whether you're an optimist or a pessimist. Anybody else have a different view of, because now we're going to have 2 or 3 AF inhibitors. There was another AF inhibitor that was presented at the meeting that looked kind of good. That was a unique construct and whatnot. It's a long ways off from being on the marketplace. This drug by MoonLake is certainly closer to the marketplace. But does
Yeah.
anyone? Yes, go ahead.
Oh, yeah, Nelly, I've got a question for you because I remember making a video back at ACR about the phase 2 of solokinumab, and one thing that had particularly impressed me back then was the high, very good response on anxiety scores, which I was quite surprised about. And I remember having a chat with some of the authors that were telling me, oh, that's because it's so small, it's going to go into the anxiety so much better, right? So I was just curious to know what was the response for anxiety scores? Was that presented?
No, it was not presented at this EULAR.
Okay, so maybe it wasn't that good then. I don't know. We'll have to see.
Maybe.
So,
Could be.
Nelly, they also presented tell us about the PROs in the study.
Yes, there was another presentation by Lorgosek. It was poster POS 0428. So the endpoints were the same study exactly, but the endpoints were the PROs, PsA, the patient assessment of arthritis pain, PGA, HAQ-DI. And so across all, I will not go into like the details, but across all these PROs, there was a significant improvement. And but this time it was in line with what was found in the adalimumab arm. So for the first outcomes, it was a little bit superior. However, here for PROs, it was almost similar. But there were very good improvement at week 12, which continued until week 24.
So Nelly, when you're looking at data like this and you see all the usual primary endpoints, ACR 20 or MDA, and PsA scores, enthesitis dactylitis, how much value do you as a clinician derive from PROs?
So PROs are softer outcomes. However, sometimes, especially in PsA, where we have a lot of comorbidities like depression, obesity, which might also affect PROs, I think they have an added value. So first, I would look at the harder outcomes, and then if it's similar, then the PROs might make a difference in my choice.
So does everyone believe that, as Nelly does, that it's icing on the cake, that PROs by themselves wouldn't be good enough, but if you add to good primary outcomes, it's another feather in your cap? Anybody, any other considerations or beliefs about PROs?
I don't know that they're going to drive me to pick a drug on the front end, but they are important because that's what is going to make the patient stay on the drug. I mean, regardless of all the sort of so-called hard outcomes that we focus on, if they have fewer swollen joints, but they don't feel well, or they still have pain and fatigue and things that haven't been addressed, they're not going to stay on the drug, especially in a space where there's a lot of options. So I think they are important.
But don't you think that they are interrelated? So, for example, a patient who does have
Absolutely.
less swollen joints, less pain at night, will have eventually less fatigue and will be more happy with the drug.
Absolutely. But you got to cover all the bases, though.
So
I think you have to think about it.
the famous rheumatoid arthritis researcher Ted Pincus spent most of his career teaching us about HAC, clearly a PRO.
Right.
And that HAC is way more important than any measure we do in a clinical trial.
Right.
It predicts outcomes better in both in the short run, but more importantly in the long run, especially with regard to, the big things: death, surgery, hospitalization, money, and cost of care. I mean, and that's a PRO. And I love hack. You can look at an 8 question, 10 question hack and know pretty much everything that's going on with a patient, or at least what you're going to have to talk about in that visit. So I do like to minimize PROs, but when it comes down to it, we're all believers in them. So let's move on. Eric, what's your big one that you want to present?
Well, I think we talked a little bit of X-ray previously, and I think we can talk about the APEX study, which was a really large study of guselkumab. So the background on this is that when this drug was approved, the phase 3 clinical trials, they did not meet their radiographic endpoints at the time, at least with the commercial dose. They met it with the every 4 week dosing, which we can't get because it's not a labeled dose. But at every 8 weeks, when this drug was given 100 milligrams every 8 weeks, it did not meet the radiographic endpoint. So they set out to show that, in fact, this drug actually prevents structural damage at the approved dose that's used in clinical practice. To do that, they did a really large study, 1,020 patients with active disease. They really enriched the population. They had to have at least 2 erosions and a high CRP just to get into the trial. And they were randomized to either 100 milligrams every 8 weeks, which is the approved dose, 100 milligrams every 4 weeks, or placebo every 4 weeks, so that they were all getting injections every 4 weeks. And the 8 week dose got the usual loading dose that we do in clinical practice. The primary endpoint was ACR response, but the sharp score was a major secondary endpoint at 24 weeks. These were pretty active patients. They had really active disease at baseline with over 20 tender joints on average, 12 swollen joints on average. They had erosions and a high sharp score at baseline. And what the trial showed was, number one, they met their primary endpoint, that both doses were better than placebo, and actually both doses were equivalent, which is interesting because there was no difference. It wasn't powered to detect the difference, but boy, they really sounded the same at every time point through 24 weeks. The numbers looked the same, which suggests that 8-week dosing may be adequate for just about everybody. I think people were thinking maybe every 4 weeks might be appropriate for some, and maybe there's individual patients, but they didn't show that. And they did meet the radiographic endpoint. So at 24 weeks, both the Q4 week and the Q8 week dosing were statistically better than placebo, highly statistically better than placebo in terms of radiographic progression. The devil is in the progression that, the two uh, guselkumab groups had a mean sharp score progression over 24 weeks of just over zero point 0.5 units, and the placebo arm had a progression of 1.35 units. What does that mean? You know, I think you got to be cautious about means, but when you think about it, that it takes somewhere around 2 or 3 sharp units for even a good radiologist to see the difference on an X-ray, that ain't much change.
Mhm.
Now, maybe over a lifetime, but nobody's going to leave patients on a drug for a lifetime just for that. And again, all of the change is as usual, is in that sort of 10% of people at the far end of the range. So they got the structural progression and it worked. So they'll be able to get this into the label and it'll be something that they can talk about and we can talk about. Is it going to change the way we use this drug? I don't know. I mean, what we're still missing is some sort of data that compares the clinical response with a guselkumab or any IL-23 inhibitor with an IL-17 inhibitor or a TNF inhibitor. We don't have that. And so until then, I don't know that this changes things, but at least we can feel confident that it does prevent structural progression at the dose we use.
Eric, was there a difference in skin outcomes between the two doses and placebo?
Not that they spoke about, they didn't give all the details, but roughly no. The challenge is that you got to be really careful about skin outcomes in a PsA trial because these are not patients with a lot of skin disease, and the ability to improve is a lot less than in a psoriasis trial where they come in with more skin disease.
But we
They were
know,
better than placebo for sure. I don't know that, but there
yeah.
wasn't a clear difference between the two doses.
But the strength of the 23 inhibitors is going to be in
Yeah,
the
the
skin
skin disease.
outcomes.
Yeah, no, it worked,
And
but
and then will the X-ray data now be their strength that they can tout with clinicians as to why you should probably be using a 23 inhibitor and not a 17 or a dual 17 or a TIC or a phosphodiesterase inhibitor. The idea is that everyone's looking for an edge, everyone's looking for something to talk about. And
Mhm.
I think Eric's giving us a realistic view of the magnitude of change here is significant, but is it meaningful? And in 24 weeks, who knows? Orly, what do you think?
Yeah, I think for me, the question I had about this trial, I mean, I know we need placebo arms and all that, but really, we have people that already have an erosive disease, and we're gonna give this 6 months of placebo. Are we all happy with that? I don't know. I wonder if, I mean, the outcome might have been different, but I think that was the exact scenario where you would want an active arm, wouldn't you?
And that's one of the problems of clinical trials these days, the ethics of it all. Jihad, this is a trial not that dissimilar to the deucravacitinib trial. Which one impresses you?
I think having heard both, they're pretty similar in terms of it doesn't really sway me one way or another. But I think the amount of effort that went into this study makes me wonder if they were looking really that closely at erosions. They ever think to look at like hand grip strength or functionality to give it more clinical meaningfulness to be able to interpret it. So I don't think I'm now that I've heard the discussions and a little bit more time to think about it, I don't know, to be honest.
Well, this is just their first analysis, and certainly they don't have a paper in play here. It'll be interesting to see if that's what they come up with. Nelly, any comments on the study?
Yes, I think that in these patients who are very heterogeneous, it's not this item only that will make you decide if you want to use interleukin 23 or deucravacitinib or interleukin 17. It's the other phases of the disease, if they have also axial disease, if they have like Crohn in the family, if they have a risk for, I don't know, thrombosis, smokers, etc. So all of this will make you decide and not just this 2 points of progression on radiography. As long as you control the disease and you control it well, I think this is objective.
Yeah. I think
Yeah,
those are all important points. Yeah.
I can add, Jack. I mean, I agree with Nelly. I think that radiographic change is kind of table stakes at this point. It's not going to be a reason you pick a drug, but if you have an instinct to use one particular drug for whatever reason, the particular domains or safety issues or convenience issues, then this at least gives you the comfort that you're, preventing progression if you choose to use that drug. But I don't see it as a reason to pick this drug preferentially or any drug largely at this point.
All right. I'm going to challenge our faculty to give me a 2 or 3 sentence synopsis of the next study that impressed them. We need to wrap up pretty quick here. So, Orly, go ahead.
Right. So OP0090, combination of biologic and targeted synthetic DMARDs in severe PsA patients. Case series. So, no control group, no nothing. But we all have a few patients like that in our practice. I certainly do. And that makes me feel a bit better to see that the tolerance looked fine in this series. No severe infections. Obviously, it's 22 patients. But yeah, I think it'd be great to have a kind of global registry of these patients and up the numbers to feel a bit more comfortable, because sometimes that's all we've got.
Yeah, a lot of people want to hear about combination. There are combination trials, well-done trials being done that we'll hear about. In the meantime, we're left with anecdotalism. Um, uh, if they had 3,200 patients that were anecdotal stories, maybe I would pay attention to this. 22 or 58, I don't know, it means pretty much nothing to me because it's a reporting bias more than anything else. Dr. Lee, what's your short one?
It's to listen to patients as we as clinicians look at efficacy to understand that patients are more concerned about safety issues. Because there was a poster, POS 114, where they surveyed 200 patients to ask about medication non-adherence. We know RA historically it's high. I would think I was surprised by this because psoriatic arthritis patient had higher non-adherence. And one of the main cited reasons was the complexity of regimen, but concern for side effects. So I think we, as clinicians, often focus on efficacy, but we need to be able to better convey risk benefit ratios and trade-offs for our patients. So just to have them involved in the conversation, in studies, and also guideline developments.
Was there any concrete takeaways from this adherence study about how we can be better at adherence in PsA?
It didn't get to the points about how patients want information translated, but I think that's an excellent question and one where there needs to be more explanation about what kind of, decision aids or information packets. Is it better coming from a peer or a caregiver? I think those are all things that we need to be more cognizant of when we develop these guidelines or how we practice.
Yeah. Eric, why don't you give us your final short one?
Yeah, so EULAR presented their assessment and recommendations for difficult to manage and treatment refractory PsA. And this is something we're doing in RA and in XPA as well. And GRAPPA presented their assessment at the ACR meeting. And basically, somewhere around 10 to 20% of patients are difficult to manage because they failed at least two targeted therapies and have ongoing disease or problematic to manage disease. And within that, about a third of those have truly treatment refractory, where they have inflammatory disease that's not getting better. The rest of them have central pain or challenges with tolerability or other issues. And I think GRAPPA and EULAR ended up at the same place, so it gives us a way forward, although their terminology was different, and that's going to take some time to try to get an agreed on terminology for what we call these things.
So the bigger group was complex to manage and
Yeah, it was complex to manage or difficult to manage. So
right.
EULAR called it difficult to manage. GRAPPA called it complex to manage. GRAPPA had patient partners. They didn't like the word difficult in there because it implied that they were difficult patients, that they were difficult to work with. So they took it out. But EULAR apparently had patient partners there as well, and they didn't have problems with the word. That's it. And then the GRAPPA group, then a subset is difficult to treat. EULAR calls them treatment refractory. I think they're talking about the same people. It's just they need to probably harmonize the terminology so that we can move forward and try to get recommendations for how to manage them.
What I don't like about this is that the bigger group, complex to manage, difficult to manage, can be up to 30% or so of patients.
Right.
The smaller group, the refractory ones, is a third of that. It's like less 10% or so,
Right.
or
Or less.
and they, but the assumption is that more, um, excuse me, refractory group are the ones that have inflammation. And I think that that is not true at all, because they are the more difficult patients and may fail more therapies. If they want to have it so that one of the criteria is going to be inflammatory markers, right? Evidence of synovitis, acute phase
I think
reaction.
it is, Jack, though. I think that's what they're trying to do. I think that because the issue is those are the people where either changing to a new mechanism or a new drug may actually help. The other ones are people where there may be other issues and maybe adding something to treat central pain, adding cognitive behavioral therapy, other things may actually be a better way to go than changing their primary, medical treatment.
See, but they're trying to do this as a Venn diagram, a big
Yeah.
circle and then a circle inside that's smaller, and that you can identify those people, and they're the ones get the expensive new drugs. And I don't think that that's true at all. What they did in RA is they just called it difficult to treat RA with a EULAR definition, failed two biologics or more, agreement by the patient and doctor. And then after they made that decision, they came around to the smart decision of saying you're either a PIRA or a NERA. You either have non-inflammatory refractory RA, or persistent inflammatory RA. And persistent
Right.
inflammatories do have inflammatory markers, and you do give them biologics and
Right.
inflammatory meds. And the NERAs are the obesities, fibromyalgias, depressions, and whatever. Again, that doesn't conform to the Venn diagram issue.
Well, it kind of does. I think they're trying to get to the same place. I think they just have to figure out what they're calling them. I
Okay,
really
so
do.
I want to hear what Nellie and the rest of the group think of this construct.
So the idea of this is not really meant for us, for clinicians to use, and it's more for research. So I think that what they want to say that they want to identify people who are homogeneous, a homogeneous group that might benefit from more research in this area. Because if you put inside the comorbidities, the fibromyalgia, the pain sensitization, and the inflammation, and you use a drug, you will not really have clear outcomes. Whether if you put like very similar patients, like those with inflammation, synovitis, high CRP, then you might be able to reach more meaningful results in a clinical trial. This is how I see it, and this is maybe the rationale of grouping this small group together.
Gia, what do you think, Gia?
Where I would like for it to see it go is with all these talk about precision medicine, AI, pharmacogenetics, is right now we're only identifying these patients after they've failed 2 to 5 medications, which takes years and it results in damage accrual. So if there's some way through research or clinical practice we can identify them earlier on, it would be fantastic. I also like that we're now starting to really recognize that there are treatment refractory non-inflammatory patients. I think that's really going to shape how we talk about conversations, also lead to research about does treating multimorbidity related to RA improve response to treatment, improve outcomes. So we're not, practicing within the singularity of rheumatology, but I think one of the notable sessions was rheumatology meets hematology, rheumatology meets cardiovascular. So there's more cross-disciplinary pollination and understanding of how to coordinate care. And I think that's where the future rheumatology and outcome improvement can be achieved from.
Orly, what's your perspective?
Yeah, actually, I've interviewed Stefan Siebert, and we've quite talked about that quite a lot. He was the co-convener of the EULAR definition. But what we were discussing a lot is stratification. And so that goes back to the PIRA and the NERA, and that's how important that is. Because then when we're going to propose trials, we want to be able to propose adaptive trials with intervention that probably won't be not non-pharmacological in the NERA people, mainly. And how we want to make sure we make that happen in a way that targets the right people into that huge big group of difficult to treat.
Eric, make sense of all this for us as we close out.
Yeah, I think, Jack, nobody's saying that the people who don't have inflammatory disease aren't important. I think that's really important, but you've got to know what the issue is. And rheumatologists, even in clinical practice, need to address that because those are the people that need duloxetine or some other treatment for their central pain. They need a GLP-1 for weight loss. They need things that we don't necessarily always do, but need to start doing because we're so focused on the inflammatory piece of the disease. So I think it's both groups that are really important for us to recognize and address in practice.
I want to thank our faculty for such hard work last week in Barcelona and for a great overview of highlights from the meeting. For those of you out there, there are other topic panels. We have one on RA and also one on SPA. Look for those as either a video or